the Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, is pleased to welcome you to our May End Use Presents webinar on substance use and responses during the COVID-19 pandemic. The End Use PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us this afternoon. My name is Erin Artigiani, and I'm the End Use COI. Barbara Kerr, Marwa Al-Nasir, Lily Warren up in New York, and I will be the facilitators for this webinar. We are part of the End Use Coordinating Center team based at CSER, the Center for Substance Abuse Research at the University of Maryland. For those who are interested, you can find detailed information about End Use, recordings of prior webinars, and invitations to future webinars on our website at www.enduse.org. You will also find instructions for how to join our End Use network and participate in ongoing discussions with nearly 1,700 experts and concerned citizens from across the United States and many other countries. We developed the End Use Presents webinars to work with leading substance use experts to explore emerging drugs and timely drug-related topics. Today, we are excited to be joined by two presenters from the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene. Our first presenter will be Dr. Denise Paone, Senior Director of Research and Surveillance. She will be followed by Michelle Nolan, Senior Epidemiologist. This webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentations. Please do not raise your hand, however. Instead, we ask that you please post your questions in the Q&A box. We will hold a Q&A session after the presentations. Our presenters, Barbara, Marwa, and I will do our best to get to all of your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar and copies of our presenter slides will be made available on our website, which again is enduse.org. Look for them under the Resources tab. Thanks again for joining us. We hope you all are faring well in our new normal and staying healthy, and we hope you enjoy this End Use webinar. So Denise, I'll pass it off to you.
Thank you, Erin. Thank you for inviting us to give this presentation today. So we're going to speak today I'm speaking with my colleague, Michelle Nolan, who's a senior epidemiologist, and we're going to talk about substance use and responses during COVID-19, and how the New York City Department of Health and Mental Hygiene is responding. So we're going to talk about a little bit about COVID-19 in New York City, as well as substance use during this pandemic, and then speak a little bit about some of the guidances that we've issued as the health department, a little bit about what's going on with SSPs, syringe service programs, and then really focus on the methadone delivery system. So as of 5/17, these are the data on COVID-19 in New York City. There are 190,408 cases with 50,120 hospitalizations, 15,888 confirmed deaths, and 4,832 probable deaths. This slide here shows the racial disparities in COVID-19 cases. There are three metrics here: non-hospitalized, non-fatal hospitalized, confirmed, and probable deaths. If you look at the left-hand slide on non-hospital and across it, the theme is that the rates are much higher among Black New Yorkers, followed by Hispanic, Latino New Yorkers. But that's particularly, there's a large difference if you look at the confirmed and probable deaths, where the rate is more than double for both Black New Yorkers and Latino New Yorkers compared with white New Yorkers. This here is showing the daily number of people admitted to New York City hospitals for COVID-19. This only goes back to 5/7, but as you can see here, we are below the line we want to be, and we're on a downward trajectory. If we actually showed this data from much earlier on during the surge, it would have looked much, much different, but we came through that period. This here slide is showing the percent of New York City residents who test positive for COVID-19. And you could also see here that we are on a downward trajectory in New York City. So now to talk a little bit about the pandemic and substance use. So we know that the coronavirus has shifted many things, including in the context of substance use routines and settings, as well as the related support and resources that are generally provided and available. So I want to talk a little bit about that. So how does COVID-19 affect substance use? So one of the issues that we've been focused on, our messaging for COVID focuses on isolation and physical distancing, which is very much opposite of our general messaging to people who use drugs. We also know that in New York City and around the country, there's been a loss of income for many, many people. As I mentioned, there are barriers to resources and material needs. And we know that in New York, that New Yorkers are experiencing increased anxiety, increased probable depression, and above average financial stress. And so all of this has the potential to increase chaotic substance use. So how is it particularly affecting people who use drugs? Underlying health conditions increase risk for severe illness. And some housing environments, particularly congregate settings, of which we have a lot in New York City, as well as housing instability of any kind, really make it difficult or impossible to follow COVID-19 prevention measures. So that's an ongoing challenge that we are dealing with. And I'd like to hear later from others of you who, and the ways that you are actually addressing that. Also, social distancing measures may increase risk of fatal overdose because we always message on how people should not use alone. There's also been disruptions in the drug market. There's increased risk of withdrawal due to change in drug availability. The unstable drug market contributes to chaotic drug use, which result in increased risk of overdose. That's coupled with syringe service programs that, at least in New York, there's limited program operations, partly because of short staffing, lack of PPE, lack of soap and hand sanitizer. Limited supply of sterile drug use equipment in the naloxone also may result in increase in bloodborne infections and fatal overdose. And then there's been less testing for HIV and Hep C. So we'll talk just very little bit about preliminary data on drug-related health consequences. So as I mentioned the other day on a call, that we are very concerned about potential increase in drug overdose during the pandemic. The number of non-COVID-19 related ED visits in New York City across the board are below expected, and that's happened since the beginning. The rates of drug-related ED visits have substantially decreased. We're starting to see an uptick, but what we are observing in the data that the rates are still below the 2019 average. So we continue to monitor our drug-related ED visits through our daily syndromic surveillance. So now I'm going to just talk a little bit about some of the health department's responses. Also, alcohol has really played a big role and a great concern of ours during COVID-19. So we've done some messaging on mindful drinking to talk about how stressful events like COVID-19 change the way people are consuming alcohol. And we know that people are reporting consuming more alcohol in the past couple of months. So some of the messaging has been around to take note, the typical harm reduction messaging, to space drinks over time and to alternate with food and water, and to avoid mixing with drugs, particularly sleeping or pain pills that could increase risk for overdose. Here are some of the messages: to stock up on naloxone and sterile drug use equipment, to avoid using alone, but to maintain physical distance with people you're with. And if you live with others, to let them know you are using, and create an overdose safety plan that includes having naloxone visible. We've also messaged on to use disinfecting products to wipe down packaging, supplies, and surfaces before use, to prepare drugs yourself, to contact the local syringe service program to see if they're delivering sterile supplies and naloxone, and for those injecting to avoid sharing works, rinse supplies thoroughly if reusing, and do not lick the needle. If use pipes, bong, straws, or e-cigarettes, avoid sharing and use an alcohol swab to wipe down parts that touch the lips, nose, and hands. We also issued guidance to our syringe services programs. So New York State Department of Health actually deemed SSPs as essential services. The programs are distributing additional safer drug use supplies to those that they're in contact with, and have also been able to increase food distribution. But there's really been a lot of changes across the programs in New York City. There's been a suspension of in-person groups, reduced services and hours. However, they are giving an increased number of syringes to all participants. And most buprenorphine services are continuing virtually. The health department has secured masks, non-latex gloves, hand sanitizer, sanitizing wipes, and garbage bags to provide to the 14 SSPs in New York City. And we made masks available for both the staff and participants. And the health department is in regular contact with the SSPs so that we can understand what their needs are and what they're seeing out in the community. So I want to just talk a little bit about buprenorphine and methadone treatment during COVID. So I'm sure many of you are familiar. This is from a recent JAMA article. And really what the bottom line on this slide shows is that methadone and buprenorphine, their study, were associated with reduced overdose and opioid-related morbidity compared to no treatment. However, naltrexone, inpatient treatment, and intensive behavioral intervention for OUD were not. And so this is where, during this epidemic, obviously access and preventing disruption of MOUD is really important. So I'm sure many of you are aware that there were changes to buprenorphine. On March 31st, telemedicine can now be used for buprenorphine induction and prescribing. People do not have to be seen for an in-person examination. That's been waived. And primary care providers and SSPs are using telehealth in New York City. Also, our major public hospital system, H&H, opened a virtual buprenorphine clinic for current and new patients. We all know that methadone is one of the two medications that's a gold standard for the treatment of OUD. However, it's highly regulated and only available at specialized opioid treatment programs. We also know that individuals in methadone treatment may experience and likely experience withdrawal symptoms if they miss a dose. Anyone with COVID-like symptoms unrelated to a pre-existing health condition must stay home. So in New York City, this is a really big challenge. I mean, we are fortunate enough that we have a large methadone system. We have approximately 28,800 methadone patients, and over half are aged 45 and older, which also has implications during this COVID pandemic. So on March 16th, the methadone regulations were also relaxed. The DEA permits doorstep delivery of methadone to people in quarantine or isolation. SAMHSA permits methadone programs to provide medication under blanket exception, up to 14 doses for clinically less stable patient and 28 doses for clinically stable patients. New York State OASIS, which regulates all the OTPs in the state, recommends 28 days of doses for patients with COVID, and 7 to 28 doses for patients already qualified for take-home doses. So these data here, there are 68 OTPs in New York City, and the health department, the city health department, is in contract with 21 of those programs. So we were able to, and we are weekly collecting data from them to understand what it looks like, the day distribution. So what we know now is that 66% of patients receive 7 or more days of medication per dose, but actually it's only 17% are currently receiving a 28-day take home. I'm now going to turn it over to my colleague, Michelle Nolan.
I'm going to talk about the methadone delivery system and give you an insight into some of the modeling that we did to determine the scale and the scope of this system. So as Denise mentioned, isolation presents a problem for people in methadone treatment. And it's critical to prevent methadone treatment disruptions while observing COVID prevention guidelines. So the New York City Health Department is delivering methadone to individuals who are in isolation or quarantine because they have COVID or COVID-like symptoms or at high risk of experiencing serious illness if exposed to COVID. Before setting this up, we really wanted to model the demand for such a system because, as Denise mentioned, we have over 28,000 individuals currently in methadone treatment in New York City. So something of that scale and scope had the potential to get unwieldy quite quickly. We were first most interested in the number of individuals who would fall sick with COVID throughout the course of the epidemic. And this is something that we modeled several times as the conditions in New York City changed. So in order to do that, we estimated the reproductive rate, the period in which an individual would be infectious, the percent of the infections that were asymptomatic, because early on, New York City was not doing widespread testing. And so the only way to know that you were likely sick was either a positive test result or experiencing symptoms. We assumed that anyone who was sick but asymptomatic would continue to go to the methadone clinic to pick up their medication. We also took into account the course of the COVID illness. So we assumed that 80% of symptomatic individuals are isolated for the duration of their illness, and those individuals would need delivery service for the duration, a period of which generally ranges between 10 and 21 days. However, the literature suggests that about 20% of individuals experience a more severe course of illness. We expect those individuals to need delivery services for the first initial 11 days and then ultimately be admitted to the hospital on or around day 12. Once these individuals are hospitalized, either in a typical hospital or in a field hospital setting, the hospital would then assume the responsibility for methadone dosing. And then we also assume that once individuals were discharged from the hospital, they would not necessarily need delivery services because they were sick. And then one of the last assumptions that we made was that once individuals were symptomatic, individuals would remain on the same dosing schedule. And this is something that we actually played around with a lot to determine what sort of assumptions in the model were most sensitive to the demand on the delivery system. So our general approach was that we built a SEER compartmental model coded in R. This stands for S, susceptible, I, infected, R stands for recovered. And we shared these findings with the Office of Addiction Services and Supports. And this model was used to inform programmatic decisions, and it was revised to account for programmatic changes. So one of the things in particular that I mentioned was that dosing schedule. And one of the things that we learned was that minor changes in sort of epidemiologic features, such as the reproductive rate, were not associated with substantial changes in the demand for delivery services on a particular day. However, the model was highly sensitive to the take-home dose schedule. And, you know, intuitively this makes sense, but it was really helpful to be able to show this in picture format to individuals to inform their thinking. So implementing the methadone delivery system. So we worked with OASIS and COMPA, which is the trade organization for medical treatment professionals, to develop this system. DOH-MH staff are delivering methadone to both patients, whether or not they're isolated in hotels or at home. And this ensures that individuals who are diagnosed with COVID or experiencing COVID-like symptoms or are aged 65 and older and have comorbidities can continue to access methadone treatment. And early on, it was really important to understand sort of the proportions that would fall into these buckets. So, first, it was important to take care of individuals who are sick and in isolation, and for those reasons could not leave their home. Once we had a solid understanding of what that burden was like, we were then able to add on the home delivery component and do what we're calling like preventative delivery. So delivering methadone to people who are really at high risk of severe COVID illness. So I talked about the eligibility criteria for methadone delivery. So first is that, COVID sick, so COVID positive or experiencing COVID-like symptoms, or individuals who are age 50 and older and have a chronic condition, and the opioid treatment program was willing to provide a minimum of 7 days of medication, or at the discretion of the medical director of the OPT program. And importantly, I should note that, we have 28,000 people who are in methadone, and over half are age 45 and older. So that's why the criteria, the second one, it's 50 and chronic health condition and at least a minimum of 7 days, because that allows us to reach sort of the most number of people who are at the highest risk. And then we have that catch-all category, just in case there's anyone that a methadone director feels would really benefit from the service, but doesn't exactly fall into those criteria. So in terms of the logistics of how this all works, medical directors at licensed opioid treatment programs identify eligible patients. For isolation hotels, site supervisors or agencies refer individuals to hotels and identify the eligible patients. The health department receives the names of patients who require delivery from OASIS and opioid treatment programs and dispatches a courier as well as a driver to fulfill these requests. DOH-MH staff pick up the methadone doses from opioid treatment programs and deliver it to patients in their homes or at isolation hotels. The medication arrives in a lockbox for safekeeping, along with a naloxone kit. And there are currently 10 delivery teams consisting of 1 volunteer driver and 1 volunteer courier. And I should note that regulations currently prohibit individuals with a history of substance use disorder from being couriers, which is the individual who physically transports the methadone. So safety was an important consideration as we're setting this up, and there are several protocols to ensure staff safety. We provided personal protective equipment. We've provided a lot of cleaning supplies and protocols for regular cleaning of vehicles. We cohorted shifts so people maintain the same contact. Each courier is paired with the same driver for each shift. We set up a whole system to capture electronic signatures, so there's no paper involved in delivery, and individuals who are isolating at home do not physically have to sign for the medication. We came up with a whole PIN system to confirm delivery receipt instead of a physical signature. There are protocols for maintaining distance from sick patients, and there's staff and escorts when escorting methadone out of the opioid treatment programs. And when delivering to a person's home, we actually do the drop off of the medication outside the home itself. Now I'm going to speak about challenges and lessons learned. So the delivery protocol had to account for a number of protocol priorities, including preventing treatment disruption among patients, obtaining delivery requests with ample time to plan deliveries, abiding by DEA and SAMHSA regulations, and ensuring the safety and health of delivery staff. Initially, there was low initial utilization of the methadone delivery system, and in response, DOH-MH expanded the recommended eligibility criteria and emphasized that opioid treatment program medical directors should exercise their discretion in referring individuals for delivery. We found that it was difficult to convey that MDS is an intervention to prevent COVID transmission, and that delivery should not just be limited to individuals with COVID or COVID-like symptoms. Stigma surrounding the provision of methadone treatment program is prevalent at many levels, both institutional and individual, and buy-in among stakeholders at all levels is crucial to ensure that the system is utilized. So deliveries to date and next steps. So as of yesterday, we completed 54 methadone deliveries, including 38 deliveries to isolation hotels and 16 deliveries to individual homes. We would like that number to be higher and to continue to increase. We're currently trying to expand the methadone delivery system into other settings. These include New York City Health and Hospitals isolation hotels. These isolation hotels are for individuals who have COVID or COVID-like illness. New York City Emergency Management isolation hotels, again, for individuals who have COVID or COVID-like illness. And lastly, the Mayor's Office of Criminal Justice Reentry Hotels. And these are for asymptomatic individuals released from correctional facilities as also a preventative measure. Okay, so implications of the methadone delivery system. So due to COVID-19, the DEA and SAMHSA relaxed federal regulations surrounding methadone provision, and it potentially provides avenue for advocating for fewer methadone treatment regulations. And the system will be evaluated to influence future policy. Any questions?
All right, thank you so much, Dr. Paone and Ms. Nolan. You really did a great job with your presentations and sharing information about the innovative programming you have going on up in New York City. And I'm sure we're all grateful for what you guys are doing up there and continuing to look for new and better ways to reach people with substance use disorder. And I do want to take time for a few questions this afternoon. And so I can see they're starting to roll in. I'm sure you've started a lot of thought and discussion with what you've been presenting. So the first question we have here is, did you ask why OTPs were not dispensing 28-day take-home doses to the majority of participants? If so, what were their reasonings?
Yes, that's something that we have asked quite a bit about. I would say that the main reason is that the stability and however it is that they define that someone's stable and can take the 28 days. And of course, there are other issues of people that are in settings where they're not in their own room, like in an isolation hotel, or there's no way to store it. So there are some of those considerations. And that's why in the isolation hotels, it's mostly a 7-day delivery. But it's an ongoing area that we keep asking about and hoping that that will change.
Okay, thank you. The next question we have is, will there be an effort to continue these services, the methadone delivery services in particular, post-COVID?
I think it's fair to say that we'd like to think that this might have an impact on policy. And I think that some of that will depend on what we find, as we do this, and an evaluation and possible study. So yes, I think that it's possible, but we don't know.
Our next question is, how have new admissions to methadone treatment changed?
So we do know that they are getting new patients in methadone. We did ask that of OASIS, and they said they continue to have new patients starting on methadone, as well as on buprenorphine in New York.
Here's a question from someone who is wondering if you have data on deaths related to substance use disorder for non-COVID patients during the pandemic, and what that has looked like.
Michelle, do you want to take that?
Sure. So as many of you know, traditional surveillance of drug-related and drug overdose deaths relies on the medical examiner completing a death certificate. That typically includes, it includes a death scene investigation as well as toxicology. and oftentimes this can take 2+ months to complete. So while we do not have solid death certificate data for the COVID period, we are exploring doing a rapid chart abstraction process to try to identify whether or not there's been a change in drug overdose deaths pre and post, or continuing to be during the COVID period.
Our next question is from a participant who wonders how other things like injectable Suboxone once monthly is being handled during the pandemic.
We actually don't have any data on that. Michelle, are you aware of anything that we might have on that?
Nothing specific to like people initiating injectable buprenorphine.
Yeah.
So, or naltrexone. But what we can say is the regulations for those have changed more so than methadone. So for those medication, or not so much the injectable format, but for oral buprenorphine, anyone starting doesn't need to visit their provider in person. But if you are starting methadone, you do need to see a provider in person for your initial visit. For injectable naltrexone, that medication is administered in a doctor's office and would still require an initial first visits.
Yeah, and I just want to follow up on that, you know, as Michelle said, if someone is starting on methadone, they do need to be seen in person. And so that does raise some issues about people who are COVID positive, but we haven't been able to find a way around that. It's just the person has to be seen in person. Yes, let's leave it there.
Our next question is in regards to overdoses being seen now, what's the percentage increase as compared to pre-COVID pandemic?
Right, so we mentioned that for non-fatal overdose in New York City, for any reason, ED visits were way, way below normal. And while that's ticking up now, as our metrics are improving, it's still below what we really would expect to see. So we're hesitant to really draw any conclusions right now. Like what we know from the data that we have access to, we're not seeing an increase. Michelle, do you want to just add to that?
No, that's the million-dollar question.
Yeah, yes, and if anyone can tell us what they're doing to feel really confident and understanding what's going on with overdose in their jurisdiction, I would really be happy to hear that.
The next one takes us back to the methadone delivery program that was discussed, and is from a participant who notes that there was such a small number of deliveries compared to the number of people who are actually on methadone or who might need methadone. And do we know how much unmet need there is for people who need deliveries like this and are unable to get them, or what their outcomes have been?
Right, so one thing to just say is that about 40% of the methadone patients have a surrogate that are picking up for them. Even if you remove them, yes, the number is still low. And that's why we're really working hard to try to increase the number of referrals. We've done some estimation on need, but we really don't know exactly what the need is. I mean, if we model it out, a lot higher than 54. But I think, as Michelle referenced, now that other hotels, you know, from MOCJ and Health and Hospitals and NICEM in New York are coming online, we'll expect to see that going up, as well as once contact tracing kicks in, the numbers, I think, will grow significantly.
We have a couple of questions here from attendees who were asking about drugs other than opioids and wondering how you were reaching out to people, for instance, who may be in need of stimulant substitution therapy or other treatment for stimulant use disorder, or who have increased their alcohol consumption. So
we're trying to do messaging on alcohol, and a lot of the messaging, as you could well imagine, is online. So we are now trying to expand that into, work CBOs, the SSPs, like getting other ways of getting messaging out on alcohol and drugs. And the issue, we don't have the same level of stimulant use in New York City as many of you have in your, cities and states. So that hasn't been a particular emphasis during this period.
What other kinds of harm reduction messaging or outreach for naloxone distribution have you been doing to prevent overdose for people who are in isolation hotels?
Right. So we mentioned that in all the deliveries we make, we have a naloxone kit in the lockbox. We also have delivered naloxone to any of the isolation hotels and also communal kits so that they're around different places. And we'll also expand that to, congregate settings and so forth. I mean, I have to say that it has also been a challenge because as many of the overdose prevention programs in the city are not functioning. So that is a concern that we have. We're doing a pilot with some pharmacies for them to really step up and just give out naloxone kits. And that's just going to get started. So we're trying to do it in multiple ways that we can.
Okay, here's a more practical question. Can you share more about the staffing of the teams? What type of staff are couriers and drivers? What vehicles they have access to? How many deliveries do they typically make in one day or one shift?
So the staff are all from, most of them, I think they're all from our bureau, the Bureau of Alcohol Drug Use. Many of them come from our rapid assessment and response team. So they're health department staff. Some of them are the drivers, the others are the couriers. And because the volume of referrals is not high, like we estimate that a team could probably make 7 or 8 home deliveries and fewer for hotels, because there's much more red tape when you're going into an isolation hotel and you have to speak with the nurse or the manager, so it just takes longer. But they're health department staff that we activated through our incident command, but they volunteered to do it. And yeah, and then we just did some training with them. But they're familiar with working with people who use drugs and in harm reduction. So yeah, it's been good.
Can you comment on telehealth and how it has been used by patients for both counseling and case management?
So I don't feel like we could say that much about that. We don't really monitor it, but we do know that whenever possible, OTPs are trying to do that telehealth check-ins with counselors, but they all don't have that. And so some of it is over the telephone, which I think is part of the issue on not dosing for 28 days, because they're not used to not seeing the person for that period of time.
So here's a question from an attendee who was wondering if the drug testing protocols have changed at all, and if so, how, if you've been able to continue doing that part of the process?
Drug testing in the context of methadone among methadone patients?
Methadone, yes.
Yeah, so there's less testing going on for those that are getting longer take homes, but they definitely still are doing urine testing for those which are 33% of the population are going at least 6 times a week. So there is some testing going on. Exactly how much, I don't know. I'd have to ask Oasis that.
Okay, thank you. There's a couple of our attendees who were interested in drug trends that you may have been seeing up in New York. And one is wondering if you've seen an increase in fentanyl in substances during the COVID pandemic.
Michelle, I'm going to give it to you.
Sure. So our data on that comes from the New York Police Department laboratory testing, and we have not received data that would cover the COVID period yet.
Okay.
We can, yeah, sorry.
Have you noticed any increases in general in drug use? Have you heard anything from the field or changes in things like drug prices or drug packaging, anything like that?
I don't, we have a poll in the field that's going to help answer some of that.
Okay.
But we don't have that data in hand right now.
There's one attendee who was interested in learning more about the comorbidities that you discussed in your presentations and was wondering who conducted the review and did each MAR organization identify the OUD patients, or was that from the New York City Health Department?
Michelle, do you want to answer that when we what we used, and then we also collaborated with the medical directors, but listing of the comorbidities?
Sure. So the New York City Health Department has conducted a review of the literature and put out a list of specific conditions that increase the likelihood of severe COVID-like illness. So we used that, and we also looked to the scientific literature just to make sure that we weren't missing anything in particular, because this is a situation that continues to change and evolve. And then we reached out to some of the directors themselves and specifically OASIS, and asked their impressions of the criteria. And then there was a second half of the question that I think was around who identified the individuals at each program that would be eligible for this. So the health department wasn't involved in identifying specific individuals. That was done at the level of the opioid treatment program. And then those programs or the isolations hotels, if the individual was in isolation, would then enroll the patient in the home delivery service. So we only know about the people who are receiving delivery. We don't have any identified information about individuals in the programs themselves.
All right, well, this has all been very interesting and very helpful. We have a couple questions left, and as we go through them, we're going to pull up a short poll just to get some instant feedback from our attendees about how you felt about this webinar and how likely you would be to share it with others. So I hope you'll take a couple minutes to answer those questions. So I'm going to go now to a question from somebody who would like to know if there are still a lot of people who are accessing OTPs in person, or do you think people are discontinuing treatment during the pandemic?
So we received data on methadone census on a weekly basis, and we can tell that the methadone population has remained relatively stable in terms of the pre and during COVID period.
From an attendee who is wondering if you have any plans to use any of the data or information that you presented today or the experiences you've had with the methadone delivery program to advocate for less restrictive methadone policies?
Yes, absolutely. We are in constant contact with them.
All right, one more question here. Are you noticing any impact of COVID shelter in place, stay at home order on drug use by older teens in particular, or young adults who are now out of school?
We have concern about that, but we actually don't have any data on that.
Okay. And lastly, we have a question here. Are you doing anything to assess whether there is an increase in diversion and misuse as you make methadone and buprenorphine more available?
We have heard that there has been some increase in diversion of buprenorphine, and that doesn't really worry us very much. We haven't heard about diversion of methadone. That doesn't mean it might not be happening, but we haven't heard that. Yeah. So it's like we're at the place right now where we know we need to collect more data from the field, and it's really just been challenging, you know, considering everything that we've been doing. And as things like lighten up a little bit, I think we'll focus more on that.
All right, well, thank you very much. I'm going to just have one last question here because I keep seeing some trickle in. So this one is, in my Florida county, it can take up to 5 months to get an MEO report back confirming death by drug overdose. Do you think this may be an issue moving forward?
I think, the experience in New York City has been just, we had a large number of deaths over a short period of time, and those deaths were, any deaths that occurred at home were required to be investigated by the medical examiner's office. So they had a huge increase in their caseload, and we wouldn't be surprised if for a short period of time that delay actually increased in New York City. And that's one of the reasons that we're considering looking at alternative ways of doing more rapid surveillance instead of looking and waiting for the final confirmation of the cause of death to come back.
Okay, well, thank you so much. I really appreciate your presentations today, Dr. Paone and Ms. Nolan, and for sticking it out through our Q&A session. And we look forward to hearing more and learning more about your successes and innovations up there in New York. And just to let everyone know, we will put a recording of this webinar and also a copy of the presenter slides on the NDUS website, which is www.ndus.org. It's under resources and webinars, so you should find them there in a few days. And I will also post the network to let everyone know when it's available. So I hope that you all have joined the NDUS network and that we'll see you out there to continue this discussion. And we are actively planning a couple additional webinars for this spring. So please stay tuned for announcements on the NDUS network and the NDUS website, and look for our registration there. And we look forward to seeing you again. So thank you so much, and stay safe and stay healthy.